Yes, I think the most important thing is that you stick to time. That contributes to a significant portion of your scoring. So, if I can invite the first speaker, Gordon Golwara.
Yeah.
Presentation time is 7 minutes, so please go ahead.
7 minutes. 3 minutes of discussion.
Good morning, everyone. Getting from Ganga Hospital, Coimbatore. These type of factors are encountered in our day-to-day practice, and one of the primary goals in the management is prevention of devastating infection of bone. 60 to 70% of open fractures wounds are contaminated with bacteria at the time of injury, and the role of these contaminating microorganisms in causing infection is controversial. Culture practices have included swabbing the wound at the time of presentation, during surgical debridement, and post-debridement. The role this culture plays in the management of open fracture is not clear. Despite the surgeon's best efforts, some open fractures become infected. In the literature review, one of the study by Jackson Lee, he found that staph aureus was the most common isolate in pre-debridement culture, and the infection was most commonly called by Enterobacter in cell mass. He concluded that pre-debridement and post-debridement cultures open fractures are of no value. In another study by Parjak, contamination rate was 62.1%, and they concluded that open fracture should be considered as contaminated wound and antibiotics are given for treatment rather than prophylaxis. In another study by Settlemeyer et al., the contamination rate was 28.7%, which dominated the staph aureus, and the infection rate was 8.2%, which was also mainly the staph aureus. And they also concluded that the pre-debridement and post-debridement cultures are not useful in predicting infecting microorganisms. In another study by D'Souza and Rajgopalan, they did a prospective study of 108 open tibial fractures, and they concluded that pre-debridement and post-debridement cultures have a role in detecting infection in open fractures, and pre-debridement cultures have a better sensitivity. In this background, the aim of our study was to determine the role of qualitative culture, both pre-debridement and post-debridement, in detecting infections in open fracture, and to highlight any correlation between infection and variables like gastroenterologist classification and Ganga Hospital open injury score. These are prospective observations conducted at our hospital in Coimbatore. The study period was from October 2010 to January 2012, and there is a regular follow-up till 1 year for detection of any infection. The inclusion criteria included patients with gastroenterologist grade 2, 3A, 3C open fractures of long bone, and the patients excluded were patients who were treated elsewhere with wound irrigation or debridement, immunocompromised states, or gastroenterologist grade 1 fractures. Wound swabs were taken on 3 occasions. First was done in casualty before debridement, second was done in OT after debridement, and the third was done if there is an infection. So total 120 patients were admitted during the study period. Of these 31 were excluded, 1 died, 3 lost to follow-up. So total patient analyzed are 135 with 148 open fractures. So the result, the open fractures, 148 open fractures were distributed according to Ganga Hospital open injury group and gastroenterologist grade. So in group 1 there were 32 patients, in group 2 there were 76 patients, and in group 3 there were 40 patients. And gastroenterologist grade 2 there were 19 patients, 3A 35 patients, and 3B 86, and 3C 8 fractures were there. Femur fracture was the most common fracture, followed by femur, forearm, and humerus. Now, 148 pre-debridement cultures were taken, and out of this 148, 60 came as positive. These 60 cultures were distributed according to gastroenterologist grade and skin score as per Ganga Hospital open injury score. In gastroenterologist grade 2, 4 cultures became positive, in 3A 12, and 3B 40, and in grade 3C, 4 cultures became positive. Whereas the skin score of 1 to 2, 21 cultures became positive out of 67, and the skin score of 2 to 4, 30 became positive, and skin score of 5, 9 became positive. So it was found that there was a linear positive correlation between the hospital skin score and pre-debridement culture positivity. There was also a positive correlation between the pre-debridement culture positivity and gastroenterologist grade and Ganga Hospital muscle score. Thus, we concluded from here that the size of open wound, loss of skin, and degree of muscle injury are 3 important factors which determine the presence of contaminating microorganisms in open fractures. So the spectrum of fluoride bone was most commonly Staphylococcus, followed by E. coli, Toxilla, Acinetobacter, and Pseudomonas. 148 post-debridement cultures were also taken, and out of these only 4 came as positive, and on 3 occasions the organism which was grown in pre-deb culture was present. On 1 occasion the pre-deb culture was negative and the post-deb culture showed the growth of Klebsiella. The infection rate in our study was 14.2% with Staph aureus and E. coli were the predominant infecting microorganisms, and the most common infection was caused by Staph aureus 9 cases, followed by E. coli 8 cases, Acinetobacter 2 cases, Pseudomonas 1 case, and mixed flora infection in 1 case. So overall, 57% of cases infected by gram-negative microorganisms and 43% of cases infected by gram-positive microorganisms. Thus, Staph aureus is the single most common infecting organism, but on the whole, infection by gram-negative microorganisms is more common than gram-positive. In 21 cases which got infected, the culture was positive in 13 cases, and in two occasions, Staph aureus was present in feed culture which went on to cause the infection, and that was not statistically significant. And in one case, positive culture was positive, and the infection in that case was with E. coli and Acinetobacter. Thus, microorganisms grown in paved environment in post-development culture are contaminating agent and have no role in causing subsequent post-operative infection. Now, the infection rate in gastrointestinal grade 2 was 5.2%, in grade 3 it was 5.7%, grade 3B it was 19.8%, and grade 3C it was 12.5%. And there was a positive correlation between the infection rate and gastrointestinal grade. The infection rate in Ganga Hospital group 1 to 3 was 6.25, 14.5, and 20%. And there was also a linear positive correlation of infection rate with Ganga Hospital group. The Pearson coefficient of correlation was 0.67 between the Ganga vascular resistance grading and infection rate, where it was 0.99 between Ganga Hospital open injury group and infection rate. We saw that the Ganga Hospital open injury group is the better scoring system in predicting infection in open fractures. Now, coming to case exam, this is the first case which was having a 3 fracture of both bone legs. This is the clinical photograph and X-rays. The wound was debrided and external fixator was applied. Later on, the patient went on to have skin necrosis with infection, followed by debridement and PLD flap. And after 20 months of follow-up, the fracture healed and wound also healed. In second case, it was a 3 fracture on both bone forearm. The fracture was fixed with plate, wound debrided, and abdominal flap was done. The fracture at 4 months went on to heal well, and the wound also healed. This is again 3 fracture, problem of both bone leg with Ganga Hospital score 10. Wound was debrided and wound healed. The conclusion, Staph aureus is the most common gram-negative microorganism, is the most common overall, and as Ganga Hospital open injury is a better scoring system than gastrointestinal.
Okay, that's great. Thank you very much. Now, before we will open the floor for questions, if I can ask you one question, why do you think these wounds got infected even though the initial culture was negative? And it's not part of the study, but what is your opinion?
So basically, it is another common infection, I think, sir. Because the patients who developed the infection was not present in the contamination, and also the post-day cultures were negative on some occasions. Later on, the patient developed infection, which neither supported the predator culture nor the post-day culture. So basically, it is a nosocomial.
Can we have questions, please? Any questions? Another question. If you quoted a few American and European papers and Indian papers as well. Why do you think there is some difference between these two? Do you think there is any difference in the kind of case mix between these two groups?
The flora which is grown varies from hospital to hospital, because the infecting organism, in some study it was Staph aureus is the main cause, but in some study it was Enterobacter with Pseudomonas. So it is basically the infecting organism depends upon the flora which is present in the hospital environment.
Sure. Do you think the type of contamination of the wounds because of the mechanism of injuries might play a role?
Yeah.
For this difference?
Yes, in my study I already told that the contamination depends on the size of wound, the muscle injury, and the skin loss.
Thank you. Next speaker is Dr. Gupta.
respected chairpersons, members of faculty and delegates. It's a great pleasure, great honor to be here. I'm back to IOACON after 2008. I was doing all these fellowships overseas. So it's wonderful to be here. And our practice currently is largely restricted to arthroscopy and sports. So we'll be talking something about ACL reconstruction today. And this was a study that I did in Stockholm along with Dr. Björn Engström. So I wish I had something to declare here, but so far, nothing. A bit of background. Hamstrings have become the preferred graft in the last decade for several reasons. But if you look at this, hamstrings are actually agonists to the ACL. What happens? There is an anterior quadriceps vector which subluxes the tibia on the femur in a cruciate deficient knee, and it's actually the hamstring which puts it back. The question is, why do you want to take away something which is an agonist? This editorial in 2008 in K-Star, and the editor was no other than N.R. Eriksson, who said, why not the patellar tendon that will improve the quadriceps and keep your hamstrings as a real agonist? Why not? There's a host of papers talking about knee flexor function getting impaired after hamstring harvest. But still, we choose it, and it works very well in top level athletes. So we decided to conduct this study. Prospectively collected data 2003 to 6. It was all unilateral primary, normal opposite knee. We did isokinetic flexor strength assessments 6 months post-op. And we also did certain functional tests. Patients were in 3 groups: patellar tendon, 70 plus Russells. 943 cases, good numbers of PTB 70, 606 ST plus Russells, more men, 27 years. Surgical technique fairly standard, transtibial SCL reconstructions, all of these. Hamstrings fixed with tender button and post. Patellar tendon with metal interference screws. Patient evaluation. 6 months down the track, we take all these patients onto the anemometer, and this anemometer axis matches the transcondylar axis. And the Bardet system 3 actually then takes the isokinetic parameters. This is done in 5 repetitions, flexion and extension, at a speed of concentric contraction 90 degrees per second. And we plot the results. What do we take? ACL reconstructed knees are compared with the opposite normal knees in the same patients. Isokinetic parameters taken from the dynamometer, peak friction torque, the maximum force that you generate, and the angle at which you're generating that force. We'll also do functional tests in terms of Coulson leg hop and tegna. What would we find? The hamstrings are recovering about 90% of the strength, 6 months. 40% basis actually more than 90%. Right? What angle? Now this is the most important bit of the study. The angle of peak drops down from about 32 to about 25 in both the hamstring groups. And these are statistically significant as compared to the patellar tendon. What is happening is, post-harvest, a higher friction torque is generated in more shallow angles. How is this happening? It's basically the biceps femoris, the lateral hamstring, which is taking over, will generate its peak at a shallow angle. So the peak torque curve moves to the left. Now, we see that in 6 months follow-up in our study, about 90% strength is regained. But the flares which say that you regain pre-injury flexor strength up to 1 year. This means flexor strength comes back, right? What's more interesting? The flexor strength comes back, yes, but it comes at a shallow angle. 32 to 25. Now, when is the ACL most vulnerable? 10 to 30. That's when the quad is pulling it in front, the tibia, subluxing it out, and the hamstring pulls it back. And this is how, actually by harvesting the hamstrings, you're getting a better agonist. Surprise, but yes, that's what's happening. Functional test. There's no difference between the 3 groups on tegna. Hamstring groups are statistically better on Coulson and one-leg hop. So they've been hands down. Advantages. They better protect reconstructed ACL. Better functional results. There's no loss of flexor strength, we see that. Multiple graft combinations. Now I use in my practice 3, 4, 5, 6, depending on what I want to do and how much thick graft I am getting. The other bit is there's no difference in any of the parameters whether you take sanity alone or you take sanity and graftless. So I always take the two together. Any questions about this? That's the anatomic ACL reconstruction which we now do.
You said that the strength is not hampered, but any other disadvantage, like when you are taking any cosmetic problems like we have or any other thing?
So the few that we have encountered, one is the infrapatellar branch of saphenous nerve that is always sacrificed. But by about 1 year, I didn't include that in this study, but by about 1 year, there are papers to say that the sensation comes back. Two, there are certain cosmetic problems, yes. But if you take any other graft, if you take the quads or the patellar tendon, you have even further problems. Then these grafts taken out of the extensor mechanism, quads or patellar tendon, they will always end up with anterior knee pain. Why the KUS score is better in the hamstring group in this study is because the patellar tendon group was doing very badly in pain score. The other problem that we have had with this, the suture post, in lean and thin individuals, sometimes the screw pokes pretty much just under the skin. But then it's a very straightforward thing. If you want to take it down 1 year down the track, very rarely you have to do it, but yeah.
Right. It's a very good study done over a longer period of time. What was your role in this study?
I went on to this fellowship in 2008 and finished in 2009. So when I got in, I was given this whole pool of data, and I started analyzing donor site morbidity of all kinds of facial reconstructions. Now there's patellar tendons, there's semi-Ts, there's semi-T plus glacis, and I pulled the whole data. And then this is one, and this paper is one bit of a huge collection of data that we got.
And were any other people involved apart from the primary operating surgeon and
Myself and Dr. Ningstrom,
just two?
my supervisor here.
Any other questions? Any questions from the floor? Thank you very much.
Thanks so much. Thank you.
Let's have a break.
Could now invite Dr. Divinagar Khan.
This is point. This one. No. Good morning to all of you. I'm going to present about single stage reconstruction of bone defects using gamma allograft of the long bones. Critically sized small bone defects are usually managed by simple bone grafting techniques. However, when the patient comes to us with this kind of bone defects, it is very difficult to reconstruct, and most of the times they end up in primary amputation. And if we are attempting for salvaging these kind of defects, we have the options of either bone transport or free fibula. We all know the advantage of bone transport. However, the disadvantage being it is cumbersome. There is a poor patient complaint, prolonged treatment, pinback infection, septic arthritis can result, and there is a possibility of having poor result also. When the patient presents with this kind of bone defects, he passes through a stages of reconstruction in the best situation and ends up in achieving the complete union of the fracture. However, the total duration of the treatment is about 2 years, and he has undergone already about 8 surgical procedures, and the limb at the end is not in correct anatomical alignment. The mobilization, he could walk only after 8 months. In the worst situations, after the initial salvage of the bone defects management, he could end up in poor functional result and leading to secondary amputation. Vascular fibular graft we can use in the gaps up to 20 centimeters. The advantage being is a vascular, viable and osteogenous graft with structural strength. However, the disadvantage is that it is a complex surgical procedure. Risk of failure of anastomosis is there. There is a possibility of mismatching sizes. Patient need prolonged partial weight bearing, and there is a possibility of failure to unite. It can become infected and necrotic. It can fracture also. In the literature, there are various reports quoting about the requirement of prolonged treatment, multiple surgeries, financial problems, and ending up in poor functional result leading to secondary amputation. Now the burning question is, can allografts overcome all these disadvantages of bone transport and free fibula? Gamma allografts are safe, reduces blood loss, easy to reproduce procedure with reduced mobility. They are available in large quantities in desired shapes and sizes. The problem of allografts is we need to have bone facility. The revascularization procedure is slower than autograft, and there is a possibility of failures, non-events, infections, and graft versus host problems. In the literature, the role of allografts has been well established in the tumor surgery. However, its role in open fractures with bone loss is not yet established. Our Ganga-filled tissue bank is established in 2008, and we follow the National University of Singapore tissue bank standards. And we have 2 medical officers trained in PMH Mumbai and NUS Singapore. And from 2008 to 2011 December, we have released about 1,071 allografts. And in 29 patients, we have used structural allografts. Our source of allografts is mainly from the amputated limbs due to vascular injuries and crushed limbs which cannot be salvaged. Once the bone is received to the bone bank, it is processed through various steps of processing before it gets dispatched for clinical use. Gamma-rated allografts are safe to use clinically and they achieve high sterility assurance level. The risk of transmission is only 1 in 1,65,000 patients. Having this in background, I would like to present my study on single-stage reconstruction of bone defects of long bones using gamma-rated structural allografts. Here I am presenting a selectively group of structural allografts which the patients which otherwise can end up in primary amputation, and the total number of patients is about 29. The study period is between 2008 to 2011. The minimum follow-up period is 2 years. All the patients had metaphyseal bone defects, and the type of allografts utilized are tibia, femur, fibula, and metatarsals. 25 patients had plating and 4 patients had nailing, and average bone loss is about 12 centimeters. Electric grafts were used in 26 patients and free fibula was used in 5 patients. Our treatment protocol is bone defects up to 10 centimeters, we use structural allograft with cancellous autografts, and more than 10 centimeters we use Kaplan technique where free vascular fibula graft is inside the structural allograft. In structural allograft combined with cancellous autografts were used in 24 patients and 5 patients had a Kaplan technique. The total number of patients is 29 and 27 patients went on to unite completely. They didn't require any secondary procedures. And the 2 patients had a non-union, and there were 4 cervical sac infections, and the average allograft incorporation time is about 8 months. Here is a patient with 30 centimeters of bone defect with open suprarenal femur, and he went on to have reconstruction with 30 centimeters of distal femur allograft along with iliac crest grafts placed inside the medullary canal, and he could walk at the end of 7 months without any pain, and he has got a good range of movement. Here is a patient with 21 centimeters of bone defect which otherwise ended up in primary amputation. We reconstructed with Kaplan technique where the distal femur structural allograft is prepared and free fibula graft with skin element was harvested and it is pegged inside the structural allograft, and the bone gap is bridged with the allograft with free fibula and the plating is done, and IOACON test grafts are placed on either side of the allograft. Skin element is utilized for monitoring of the viability of the free fibula postoperatively, and it went on to neck completely at the end of 7 months, and he was able to walk completely without any pain at the end of 7 months, and he has got a good range of movements. Here the advantage being we could mobilize knee joint early and he could walk independently without any support, which otherwise if we could have used free fibula, no need to, he needs to be protected for long periods. Here is a patient with recurrent giant cell tumor of the distal tibia which was excised completely, and the 8 centimeters bone defect was reconstructed with distal tibial allograft and intramedullary graft was placed. It went on to neck completely at the end of 8 months. He was able to walk. This is the final follow-up at the end of 3 years and there was no recurrence. We had infection in 4 patients. 2 patients had superficial surgical site infections which subsided with intravenous antibiotics, and there are 2 deep surgical site infections. Both had debridement and graft removal during debridement. The first patient who had open suprarenal femur which was treated with fibula graft along with iliac crest graft went on to fail and got infected, and after debridement he ended up with 10 cm of bone defect which was reconstructed with Kaplan technique, and he had a good result at the end of 1.5 years. Here is a patient with open suprarenal femur which was reconstructed initially with distal femur structural allograft. It went on to have infection and we removed the graft, and it was reconstructed with the initial space was kept and then removed and grafted. Even at the end of 2.5 years, still waiting for complete union. To conclude,